Maternal mortality is rising in the United States. While poor health outcomes still inequitably occur among people in communities that are under-resourced, recent research demonstrates that racial disparities in maternal health cross income and educational lines. Every death of a pregnant or parenting person represents not only the loss of that person, but a profound loss for their children, families, and communities. Social and structural issues are reflected in the causes of maternal death, seen clearly in the growing substance use and violence-related causes of death.
In a statewide maternal and child-focused needs assessment Policy Lab conducted in 2020, we found that substance abuse is one of the most pronounced issues facing families across the Commonwealth. More specifically, pregnant and postpartum people in Pennsylvania had about 2 times higher rates of diagnosed substance use disorder, or SUD, compared to average rates in the rest of the nation. We also identified that in Pennsylvania counties with significant numbers of pregnant and postpartum people experiencing SUD, there were either no or very few specialized programs offering medications for opioid use disorder.
In our efforts to improve equitable access to evidence-based treatment for pregnant and postpartum people with opioid use disorder, we studied a cohort of people with opioid use disorder from around the country around the time they gave birth, using data from a national private insurance claims database. We found that just 1/3 received the FDA-approved medication for opioid use disorder, buprenorphine, while pregnant or in the year following birth.
Pregnant and postpartum people hoping to start treatment for opioid use disorder face numerous structural and social barriers in accessing and sustaining treatment. First, due to the criminalization of opioid use during pregnancy, pregnant people fear the potential loss of child custody and other criminal charges for seeking treatment. Second, medication for opioid use disorder during pregnancy requires careful monitoring and tailored treatment. However, there are too few providers trained in and able to provide this type of treatment. Third, our study points to lower medication usage during pregnancy and the postpartum period among Black and Hispanic people, which is indicative of systemic racism manifested in the criminal justice and child welfare systems policies and practices.
Another possible reason for the low treatment access rate is that treatment facilities are too far away from the homes of many people who need them. To further explore this travel distance factor, we have another pilot project underway, through which we're studying a group of Medicaid-enrolled people who gave birth in Pennsylvania and were impacted by opioid use disorder around the time of childbirth.
The answer to the question of why pregnant and postpartum people are not getting adequate access to treatment for opioid use also has policy implications. So part of our project involves conducting a policy scan, both nationally and here in Pennsylvania, to better understand best practices for opioid use disorder medications for this population to inform policy and program recommendations aimed at family-centered treatment programs.
We hope this information can inform the development of equity-focused interventions and policies to optimize evidence-based treatment access for pregnant and postpartum people, and ultimately to reduce disparities in opioid-related maternal and neonatal morbidities and mortality.